Rianti, one of our residents in Universitas Indonesia, Cipto Mangunkusumo Hospital, that will present a Nanothin DSEK. This is the promise for off-flux dystrophy, especially in our country, because this is done by Dr. Rio with limited setting, but he managed to do that. And then also there would be a lecture by Dr. Evan Wong that would talk about corneal transplantation in endothelial disease, current approach, and emerging alternative. We will start with case presentation, and then we will continue with the lecture. And sorry, I'm Rina. I will be the moderator for tonight. Dr. Firna is unavailable tonight, so I will replace her. Hopefully we will have a very fruitful discussion tonight, and we will have more knowledge, and hopefully we can implement that to our skills in our practice. So I would like to ask Dr. Rianti to start with the presentation. Please, Dr. Rianti, could you start your presentation?
Okay, thank you, Dr. Lina, and good evening, all professors and doctors. So my name is Rianti, and I'm a third-year resident and currently I'm at Cornea and Cataract Refractive Surgery Division. So here I would like to present a case of a nanothin DSEK, the promise of dystrophy, with Dr. Rio Randy as my supervisor. So let's begin with a case illustration. So this is the initial visit of a male, 69 years old. He came with a chief complaint of blurry vision of right eye for 2 months. He described a black shadow covering his vision, no white lesion or eye redness, and no other additional symptoms. At first, he went to JSA and diagnosed with corneal anomaly and got referred to RSCM. There were no history of eye surgery nor trauma and no familial history, and there are history of spectacle use. In ophthalmology examination, we found the visual acuity were 6/24 and corrected to 6/7.5 with normal IOP. The palpebra and conjunctiva were normal, and the cornea, we found an edema, bulle, and guttae with positive staining. And other parts were within normal limits, and the lens was hazy grade 2. Here's the picture at the initial visit. Actually, it was a year ago at March 2023. And for the left eye, we found the visual acuity was 6/12, corrected to 6/6. The cornea, we found a similar finding, and the anterior and other part of the anterior and posterior segments were within normal limit. And then the patient was assessed with a few endothelial dystrophy of both eyes with senile immature cataract of both eyes, and he was prescribed with sodium chloride 6 times of right eye, levofloxacin eye drop 4 times of right eye, artificial tear 6 times of right eye, and plan to do a manual DSEK of the right eye. So a year later, after waiting for the donor, he underwent a surgery of a DSEK with phaco IOL of the right eye done by Dr. Yorendi at Kirana OT on March 2024. The donor was from Nepal with the donor information with the CD is 2,841, the hex was 48, and the CV was 37. So here I will share the intraoperative video done by our consultants, Dr. Yorendi. So at first, we make a scleral tunnel 5 to 6 millimeter in length. And then we pass through the anterior chamber using a keratome. And we inject the trypan blue intracamerally, and then we wash the trypan blue afterwards. And we make a marking at 8.5 millimeters. And desmatorexis was done with 8.25 millimeters and continued with capsulorexis. So here's Dr. Rio still doing the desmatorexis first. And then after completing desmatorexis, Dr. Rio continued to make capsulorexis. And then a routine phaco surgery was done. And we inserted the IOL in the back. In this patient, we used the power of the lens is 23.4 with the target minus 1.22. After inserting the lens into the back, we removed the OVD and injected myoticum and making an inferior peripheral iridectomy. We prepared the donor, mounted the donor on the artificial chamber, and making peripheral incision with 350 micron guarded knife, and creating a pocket using a crescent knife. So we dissect the cornea manually with blunt dissector. So after fully dissect, the cornea was cutted, and then the second dissection continue with the same technique and start doing the second dissection. We use the same technique as the previous one. So after fully dissected, we make a P mark on the stromal side and we close the cap. And we place the graft and cut the graft circumferentially with 8.0 baron terfine. Okay, after that, placing the cohesive OVD on the incision area, and we place the graft with endothelial face down and push the graft using push-through technique. Injected small bubble under the graft and secure the graft by suturing the wound. After suturing the wound, we give more bubble inside the eye. Here we give more bubble inside the eye. However, we found the graft is not well centered. And then we reposition the graft by using Reversinski and trying to pull the graft into the central position and injected more bubble again. And then we give more bubble and conclude the surgery with the Seidel test. Okay, so here's the post-operative follow-ups. So here's the post-operative day 1. The visual acuity was 1/60 with IOP 20. As we can see here, the cornea is a bit clear and the bubble was filling the anterior chamber, half of the anterior chamber. And we can see over here, there's a line between the graft and host junction, and the patient was given a levofloxacin eye drop every 2 hours and prednisone acetate. And we educate the patient to do a bed rest with supine position with a pillow and limited movement. The patient was discharged and then continued to 1 week follow-up. Here is at the 1 week follow-up. The visual acuity was 1/60 with the IOP of 18 on timolol. As we can see from the slit lamp examination, the cornea was a bit edema. And then at the inferior part, it is suspected as there is a cleft or a detachment of the graft. And we make sure by performing an ASOCT. And ASOCT results showed a detachment of the graft over here. And the patient was planned to do a rebubble of the right eye at the Kirana OT performed by Dr. Yorendi. And here's the post-operative day 1, post-rebubbling of the right eye. The cornea was a bit clear with a bubble filling the anterior chamber to over third anterior chamber. And the medication will still continue, and the patient was also given a bandage contact lens. And the patient was discharged and then planned to do an ASOCT again the next week. And here are the 2 weeks post-operative. As we can see here from the ASOCT, the graft is already attached here and no other sign of detachment. From the slit lamp examination also showed the cornea was clear. And the IOP, the visual acuity was still the same with 1/60. The medication will still continue, and the patient asked to control for 1 month. And here's at a 1.5 month follow-up. As we can see here, the slit lamp is, the cornea here is really clear, and we can see here there's a line between the graft and the host from the picture, and the anterior segment also showed the graft is still intact with no detachment. The visual acuity was improved from 6/24 to 6/7.5 with spheris minus 3.5, and the IOP was normal. And the patient was asked to control again, and the medication were continued. Okay, so here's the post-operative 3 month follow-up. The uncorrected visual acuity was 6/18 with the cornea clear, and there's a line, a circle line between the graft and the host. And from this arrow showed the graft here attached, and we perform an anterior segment OCT again just to make sure the graft is fully attached and to measure the thickness of the graft. So here the anterior segment OCT showed the CCT was 473 with the thickness, the central thickness of the graft is 21 micron. So this is the central part of the graft is measured as a 21 micron. And then this is the resume of the patient. So on February 2023, he came for the first time in RSCM. And then a year later, he underwent a surgery and then still coming to our hospital to follow up until this is the present, the 3 month post-operative. So here is another case of DSEK in view endothelial dystrophy in our hospital. So this is a female, 49 years old with a visual acuity of 0.5/60 with normal IOP. On September 2023, she came and then was diagnosed with view endothelial dystrophy of right eye and then planned for DSEK of the right eye. And this is the post-operative day 7. Following DSEK and the rebubbling, the visual acuity was improved to 6/30 with normal IOP. And then we still monitor this patient because she just had her surgery on May 2024. Okay, so moving on to a bit of a discussion. So endothelial keratoplasty is a selective corneal surgical technique that replaced the diseased endothelial layer with a healthy donor endothelium. Over the past decade, endothelial keratoplasty usage continued to rise, and since 2012, it has been the most common keratoplasty performed in the US. The reasons are it provides a faster visual rehabilitation, smaller incisions, stable corneal contour, and low rejection rate. So what is the difference between ultrathin and nanothin? The term of nanothin DSEK is if the graft is less than or equal to 50 micron, while ultrathin DSEK is 50 to 100 micron. Both ultrathin and nanothin are provide better visual acuity, and this mechanism was hypothesized due to optical higher order aberration. And this is a review of systematic reviews by Coelho et al. At 2023. So the study actually compared the UT DSEK, ultrathin DSEK versus DMEK, and the visual outcome in DMEK is more superior, complication rate was lower in DSEK group. And another study, this is actually a prospective study from Kurji et al. At 2022. So this study was using 28 consecutive eyes, and each underwent a nanothin DSEK and DMEK, and with 18 and 14 eyes combined with cataract surgery. And as we know, the DMEK surgery always have a superior visual acuity due to there were no stromal layer. Conversely, in DSEK grafts do contain varying amounts of posterior stromal tissue and thus have been shown to provide worse visual outcomes if compared to DMEK. Actually, interestingly, in this study, the mean visual acuity was comparable to DMEK at a 1-year follow-up. In this graph, at the 1-month follow-up, the DMEK group was showing the better visual acuity, better BCVA. However, by 3 months postoperatively, the significant difference dissipated, and at 6 to 12 months follow-up, no significant difference in the BCVA was observed in either group. And 93% of eyes in both groups were shown improvement of visual acuity. And it can be concluded that from the study that the comparable visual outcome from NT-DSEK were achieved at 1 year follow-up. And as in a conclusion, in this graph, the advantage may be to the operator can adjust the position or centration of the donor by pulling the donor into the optimal position. In our cases, the target of best visual acuity was also achieved, and the rebuilding rate in the DSEK cases was also lower. And that will be the end of my presentation. Thank you for your kind attention.
Thank you very much, Dr. Rianti, for your clear presentation. We will gather all questions until the end of the next lecture, so we can discuss everything, the case, and also the topic. So for the next presentant, I would like to ask Dr. Ivan to present his lecture. Please, Dr. Ivan, thank you.
Thanks very much. Good evening, everyone. My name is Evan. I'm a corneal specialist in Perth, Western Australia. It's a great privilege to be able to connect with you all over this Zoom call, and just share some of the things that I'm excited about in the field of cornea, which I understand is not the usual topic of presentation for these meetings. But thank you for having me, and I just want to thank also the organizers really for the opportunity. Can I also congratulate Dr. Rianti and Dr. Rio on a very nice case presentation of some of the surgery that Dr. Rio is doing in Jakarta. That's fantastic. I work at the Lions Eye Institute as well as Royal Perth Hospital and Sir Charles Gardner Hospital as a corneal consultant, and I'm a senior research fellow at the University of Western Australia. I was looking back and wanting to find some pictures from Indonesia. So this was the last time, actually most recently I was in Bali for APAO earlier in the year, which was a great meeting. But the last time I brought my family was actually in 2018. So this is quite an old photo. And we really enjoyed ourselves. And I was looking at the photos, and at the moment in Perth, we have quite cold and wet weather. And I was missing the warm Indonesian weather. So it'd be nice to come back soon. I'm going to talk just briefly touch on four topics. Firstly, the current trends in the field of corneal transplantation, focusing on endothelial disease, a little bit of what Dr. Rianti talked about earlier, and then briefly talk a little bit about DMEK, and then some of the newer things that are kind of on the horizon. So DSO, which is Descemet stripping only, and then corneal endothelial cell injection, which is really something that's really new at the moment. So we're going to start off with current trends, and the data that I'm presenting is actually from the 2021-2022 Australian Corneal Graft Registry report, which is a very large, one of the largest corneal transplant registries in the world. There are over 40,000 corneal transplants that are registered on this database that's been going since 1985. So this is a bar chart of the total number of grafts performed each year from 2001 to 2020 for bullous keratopathy. And you can see that over the last 20 years or so, there has been an increase in the number of grafts overall. And as Dr. Rianti shared earlier, the vast majority are now endothelial keratoplasties. So, over 90% basically the only approach or the dominant approach, but as EK has become more and more widespread, then it's really taken over as an option. This is the same chart, but looking at Fuchs endothelial dystrophy. And interestingly, you can see there's a much greater increase in the number of transplants performed for Fuchs endothelial dystrophy, even compared to bullous keratopathy over the last 20 years. And you also see the similar sort of dominance that EK has now, that endothelial keratoplasties have. So in green, there's DSEK, and in purple is DMEK. And again, it's almost 100% of surgeries in Australia for Fuchs endothelial dystrophy are now one of either DSEK or DMEK. So my question looking at these graphs is, why is there such a large increase in transplants for bullous keratopathy, but especially so for Fuchs endothelial dystrophy? The Australian population has grown over the last 20 years, but it hasn't grown to this degree. And we'll talk a little bit more about this, the trends that we're seeing. This is a picture here of best corrected visual acuity in surviving grafts performed for Fuchs endothelial dystrophy. The blue box plots are for PK, and then green is for DSEK, and purple is for DMEK. And the first thing you notice is that the pre-op visual acuity for PKs tends to be a lot worse than pre-op visual acuity for the EKs, right? That's in that first sort of column there, pre-graft. And then the other thing that you see is that the visual recovery tends to be quicker for the endothelial keratoplasties, and the average visual best corrected visual acuity is, particularly for DMEK, is excellent, and it exceeds the results for even PK and DSEK. That was for Fuchs endothelial dystrophy. This is for bullous keratopathy. For bullous keratopathy, the pre-graft visual acuity is much worse because these are eyes that have had multiple operations. They have lots of other comorbidities, potentially glaucoma, retinal problems, and so the average best corrected visual acuity after the transplant is not as high, but a similar sort of trend that we see as compared to Fuchs endothelial dystrophy. So I think that in this graft here, we do see one of the reasons why we are seeing more and more grafts being performed, and that is that we are waiting less and less for eyes to get for vision to go down before we do the transplant. So the threshold for operating is much lower because we know that the visual recovery is faster. This next slide here shows the comparison of complication rates on the ACGR, and the rates of complications are much lower with the endothelial keratoplasties. So for that reason, the barrier to do surgery, it also goes down. We know that the patients will recover faster. They need less of steroid medication. We induce less glaucoma with the endothelial keratoplasties. You can see there compared to PK, 19% post-graft rise in IOP. DMEK in ACGR is only 9%. So that's quite a dramatic decrease in the risk of causing causing glaucoma with the steroid medications. And so I think that's one reason. The other reason for the dramatic increase in the number of transplants that we're doing in Australia is actually a downside to the EKs, where you can see these on the survivability graphs, in that they don't survive as long as a PK. So if you look at the 0.5 probability of graft survival for a DSEK for Fuchs endothelial dystrophy, that's probably about 8 to 10 years compared to a PK where that's more like 12 years or so. And for bullous keratopathy, it's a little bit more similar for bullous keratopathy for DSEKs compared to PK, but in both of those graphs, the DMEKs have actually the poorest survival. And we find that actually we are redoing, for example, 6-year-old DMEKs, 5-year-old, 6-year-old DMEKs sometimes. And so I think that's the other hidden reason as to why the number of transplants is increasing, is actually we're doing more transplants per patient over their lifetime, basically. Because the PKs used to last, well, they do last, a lot longer than the endothelial keratoplasties. So those are some of the current trends that we're seeing here in Australia. I'm going to just shift tack here just to talk a little bit about DMEK. I'm just going to show one of the surgical videos that I've done of DMEK here. And I'll just talk through this video as we go. It is quite a sort of a truncated video, but I'm marking the cornea here and doing a descemetorexis where we removed Descemet's membrane and the corneal endothelial cells there. I do inferior peripheral iridotomy, much like Dr. Rio was showing. And then we strip, so these DMEK grafts that we get from the eye bank are actually pre-stripped. So they strip about 80% of the graft and they leave it the last 20% attached. And then I complete the stripping in the surgery, perform a tri-fold of the DMEK graft. And I was privileged to do a fellowship with Prof. Jod Mehta in Singapore at SNEC, where I was there at the same time as Adiela, who's on the call. Hi, Adiela. And this was a technique that Prof. Jod actually pioneered, which is an endoglide version of DMEK. And so it's very much done like an endoglide DSEK, if you've seen that before, but it's very controlled. And the learning curve, one of the downsides of DMEK is a steep learning curve for surgeons. Even surgeons who've done many DSEKs find that endothelium out DMEK is quite challenging to do with a lot of tapping and takes a long time at the start. But with the endoglide technique, it's fairly well controlled. You hold the graft in place, place a SF6 bubble, and then do a full gas fill. And I'm just going to freeze frame in a second here, just to show you, while I'm preparing the graft, I also do what's called an asymmetric triangle. The graft is so thin that if it flips in the eye, you can't see which way is up. And we've also stained it with trypan blue. And I'll just freeze frame there. You can just see in the top right-hand corner of your screen, there's an asymmetric triangle that tells me that I'm in the right orientation. I fill it with, do a full fill of SF6, and I leave the eye with a full gas fill. And posturing face up for 2 hours after the surgery. So that's just that's all I wanted to say about DMEK, is that although the challenge of the surgery, the technicality of the surgery is quite a lot higher than DSEK. With this endoglide technique that Prof. Jod has pioneered, I think that the learning curve actually is a lot shorter. There were published rates of rebubbling for this particular type of DMEK surgery, and it stands at about 11%, which is fairly acceptable. Okay, just moving quickly on now to the third topic, which I'll spend a little bit more time on, which is DSO, or Descemet stripping only. And this, again, was pioneered by an Australian surgeon, Greg Maloney, as well as Catherine Colby from the States. And we have some, we're getting more and more data on DSO as an option in endothelial disease, particularly in Fuchs endothelial dystrophy. So just share a quick case of mine from last year. This lady was 60 years old, and she was actually referred to me for LASIK regression. So she had LASIK surgery about 12, 13 years ago, Marpic LASIK. She was previously at -5, -6.5. And noticed that the vision was getting more blurry. She was getting some glare in the eyes, and she refracted to, in the right eye, -1 and left eye -2.25. And so she was thought to have some regression of the LASIK surgery and sent in to me. But in fact, she actually had Fuchs endothelial dystrophy, and she was decompensating to the point where she had developed a myopic shift. She had minimal cataract at all, and posterior pole was normal. You can see the uncorrected visual acuity had really dropped off after her LASIK surgery in 2011. She was 6.6 in both eyes. You can see there 6.19 uncorrected in the right, 6.38 in the left. And so these are some of her scans, and I found her all pentacams from after LASIK surgery in 2011. And you can see that although her corneal thickness is not that high, in 2023, 571. In fact, she's had myopic LASIK, so the cornea is actually a lot thinner than a normal cornea. And so in 2011, her corneal thickness was actually 485 microns. So she's actually had quite a significant increase in central corneal thickness. On the anterior curvature maps on the left panel there, you can actually also see that her Ks, which are you'd expect them to be more flat after myopic LASIK, have actually steepened up, and that's also because of the edema. And on the posterior float of the pentacam, you can also see that she's dropped into minus values on the posterior float, which are abnormal, which are also early signs of edema. The right panel over here is the specular microscopy, and if you just take the central image there, you can't see any cells at all. And then I did some peripheral shots on the specular microscope, and you can see that there are some cells, lots of guttae peripherally as well. So the options for her, at this stage are an endothelial keratoplasty, but the problem is that she has not much cataract at all, and so some people would suggest doing just DMEK, a phakic DMEK, leaving the lens alone, just doing DMEK surgery, which I think would be reasonable. Some people would consider combine phaco and DMEK and just sort out the lens at the same time. But we decided, she was actually from the country, so she was a 2-hour flight from Perth, and she wasn't looking forward to multiple follow-up visits and things. And unfortunately, at the moment, we can only do corneal transplant surgery in the Perth metro area. And if you've ever been to Western Australia, we cover, WA is a a huge state, and for country patients, access to this kind of care is quite difficult. I shouldn't say huge actually compared to Indonesia. We're a big state, yeah. And so I discussed doing Descemet stripping only with her, and she was prepared that the recovery would potentially take maybe 2 months, and if it failed, she would still need to come down for an endothelial keratoplasty. But we decided to proceed with that. So this is my surgical video of Descemet stripping only. I marked the visual axis at the slit lamp, and then after that, I added these corneal marks of a 4mm diameter. This was done under local anesthetic in the operating theater. So I inject some local anesthetic, just intracameral lignocaine here, as well as Provisc. So I haven't dilated the pupil. Some people will dilate the pupil to get a better red reflex, but decided not to do that. And I had enough dilation just with the Provisc. And the technique here is really a Descemet peeling rather than stripping. So one thing that's been shown in published reports is that if you do a descemetorrhexis like you do it normally for an endothelial keratoplasty, where there's more sort of scraping on the posterior stroma, it actually causes inflammation at those points, and it causes these posterior stromal ridges to form. And that can be very difficult for the peripheral cells to migrate across. And so, sorry about it's moving out of the screen there, but what I've done is I've just scored the Descemet's membrane, and then with a pair of MST forceps, I'm very gently peeling away the Descemet's membrane without contacting the posterior stroma. And I'm just trying to join the dots, basically, of that 4mm diameter circle. So you can kind of see it there just in the red reflex, that clear area where we've removed the central guttae. And then I just wash out the viscoelastic and then close up, and that's it. So the surgery probably took about 10 minutes to do. This was her eye at post-op week 1. And the vision, if you remember, she was 638 pinholing to 6 on 30. And she told me in that first week, everything's just gone cloudy. So she can't see on that side. Vision's dropped off to 6 on 240. And on examination, you can see this honeycomb central edema in the eyes there. You can also make out her LASIK flap there as well. But that just where I've peeled, you can see that edema there. And on ASOCT, I've just put dotted lines there to show where I've peeled the Descemet's membrane. And you can see that quite significant edema. Her corneal thickness has gone up, over 1,000 there. This was at month 1, and she told me that at about week 3, all of a sudden, the vision started to clear up. I should mention also, sorry, that I've at this point put her on Maxidex 4 times a day, which is dexamethasone, and also ROCK inhibitor. So we use Rapacidil 4 times a day as well. So you can see after 1 month, the corneal thickness has gone down to 450 microns, and the edema is basically resolved. Visual acuity still hasn't quite picked up there yet, but that continued to improve over the months, and these are her results at 6 months. Remember, all we've done is just strip the Descemet's membrane. I haven't done anything else for her. Her visual acuity has gone from 6 on 30 in the left eye to now unaided 6 on 7.5. You can see there on the specular microscopy where there were no cells. Now at 6 months, we have a cell count of 1,193. And you can see those cells, they are obviously larger than usual. There's polymegaphism and polymorphism, but they're working. What I have here in the right panel here is corneal optical densitometry, which you can get on the Pentacam device. And this was pre-op here. You can see that scatter of light from the central cornea, both from the corneal edema as well as the guttae, and that's all resolved in the left eye there. So she's very happy with the vision. Interestingly, even her myopic shift has resolved to minus 0.25, which was essentially her post-LASIK refraction. And that's because the steepening of the cornea has actually flattened out again. And so she's very happy, and we're planning to do the right eye for her now as well. So she knows that down the track, she may well need an endothelial keratoplasty, perhaps at the time when she has cataract surgery. But we've bought her some time, and as long as her cornea doesn't decompensate again, we can hold off any other procedure for her. So there was a recent meta-analysis of all the published cases. This was from back in 2022 by the Canadian group, I think the Toronto group, with Alan Slomovich. And they included in their meta-analysis 67 individual eyes and reported an overall success rate of DSO of 85%, with an average of 4.9 weeks to clearance with ROCK inhibitor. And they also found that the 4.0 diameter peel was the sort of associated with the highest level of success for DSO. They showed so one group had ROCK inhibitor and the other group didn't. This is not a randomized controlled trial. It's just a retrospective meta-analysis, but there's a significant difference of mean time for corneal clearance of 10 weeks without ROCK inhibitor and 4.9 weeks with ROCK inhibitor. So I wouldn't consider doing this without ROCK inhibitor. And it's much more beneficial to have that. The other thing is also that the endothelial cell count is higher in patients where they had used ROCK inhibitor. For the cases that I've done, I would keep the patients on ROCK inhibitor 4 times a day for at least 2 months. This was the algorithm that they published in that paper in terms of how they see DSO fitting into their practice. And I would sort of think in much the same way. Basically, if there's central guttae, central low to absent cell count and a clear periphery, then you can consider DSO as an option. I think DMEK or DSEK surgery is still excellent surgery and with good recovery and low complications, but you're still subjecting the patient to much longer, and in some cases, lifetime topical immunosuppression with steroid eye drops, a lifetime risk of inducing glaucoma. Whereas with DSO, we use steroids for a month and then we stop the steroids after that. So there are benefits, I think, to this minimally invasive approach, and I'm finding that I'm beginning to fit this into my practice as well when I see patients with endothelial dysfunction. Okay, just on to my last topic here, and that's corneal endothelial cell injection. And this is, as I said, a much sort of more still in some ways experimental type thing. This is, I'm sure many of you recognize Professor Shigeru Kinoshita is the current president of the Asia Cornea Society, and he's coming to Jakarta in September. And so he's very much been the pioneer. We had the great privilege of hosting him here in Perth last year for our national meeting. And he gave a fantastic lecture here. So he's pioneered this idea of culturing donor endothelial cells. So these are cadaveric endothelial cells. And we retrieve the corneas much in the way that you retrieve them for a corneal transplant. And then through a series of culture processes in a specialized lab, these cells are expanded and the population is expanded. They're not stem cells, they're terminally differentiated endothelial cells. And in the eye, they don't tend to proliferate or multiply, but in the right conditions in the lab, we can get them to multiply and proliferate. And then you start off with one cornea worth of endothelial cells, and after a culture process, you can end up potentially with 80 to 100 times the number of endothelial cells from that single cornea. And so the great attraction of this approach is firstly that potentially you can expand the number of donors that you have by this process of cell culture in a laboratory. The other benefit to this approach is that what he found was that just by wiping off the corneal endothelial cells from the Descemet membrane in the recipient cornea, and then injecting these cells with ROCK inhibitor and positioning the patient's face down for 3 hours, they found that they achieved corneal clearance fairly quickly and also with good long-term results. So they published their 5-year data I think this was end of 2021. Clear that you can see these are results over the 5 years. No complications and maintenance of good BCVA and healthy corneal thickness as well. So the results are quite dramatic, and there really hasn't been another a substantial publication on this since then. There are currently clinical trials that are ongoing in the States, and more and more patients have been done using this technique, but we're still waiting to see the published reports of this. Here in Perth, we are trying to get this going as well, and collaborating with my previous supervisor in Singapore, Prof. Jod. We are beginning the process of learning how to culture these cells and manufacture these cells. What I do is this is a map of Perth City here. I work over here at Lions Eye Institute, and that's where our Lions Eye Bank is situated. And we harvest, or we retrieve donor corneas from here, and then we drive them across Kings Park and across the city to Royal Perth Hospital, where we have a lab that's set up that can do this work. So it's called the Cell and Tissue Therapies WA, and they're an accredited facility for cell culture and cell therapy. And we culture the cells there. These 6 panels here show over a period of time, so over 72 hours, the proliferation of the cells in culture. And this over here is a little video which actually represents 24 hours, and you can see the cells proliferating, moving around. They're very cute. We have this live cell visualizer. You can see this little cell looking around for some friends there. And so we have this current project. It's a pilot project going basically to be able to start culturing these cells. This is yeah, sorry, that's yeah. So that's on corneal endothelial cell injection. We are looking forward. The next step for us basically is to try and move forward with clinical trials with this. And Japan has already begun that is commercially available as of this year in Japan. Under the name Visnova. So that's very exciting. I think that's something that's on the horizon. So in summary, thanks again for letting me share on some of these topics, which are very exciting in the world of cornea. In terms of the current trends, we're seeing that the number of transplants is increasing, and they're mostly endothelial keratoplasties, particularly for endothelial disease. But even sort of overall, so in Australia, DSEK and DMEK are the most performed transplants at the moment. Endoglide DMEK is something that I've been fortunate to learn, and I find that the learning curve is much shorter, and it's been a very reliable technique. DSO, I think, is an option to consider for Fuchs endothelial corneal dystrophy. Patient selection is very important, and the patient sort of needs to be briefed that the vision will get much worse, and if it fails, then they'll need a transplant. But I think it's an option, and particularly for phakic patients, I think, where you have that difficulty in trying to figure out what to do with their clear lens. And as a CECI, I think that's something that's on the horizon. I think it's something that could potentially solve a lot of the transplant shortage that many countries face. And if it really works in this minimally invasive way, then the opportunities, I think, to put this into place and to help people, particularly who don't have good access to eye banks and corneal transplant surgeons, where the cells potentially can be shipped out and injected in a more minimally invasive procedure. I think that there's really great promise with that, and it's something that's going to be very exciting. So I just want to thank, these are my references here. And just want to thank my collaborators. These are my contact details. Love to connect with anybody who's interested. And this is a picture of my family here in Perth on Rottnest Island. We've got these little creatures that are called quokkas. And yeah, we'd love to be able to see some of you making it over to Perth and be able to connect in person. But thanks very much for having me, and happy to take any questions.
Thank you so much, Evan. What a wonderful lecture. I'm very enjoying your lecture. So I hope I will give the opportunity to the audience. We have around 140 participants now in the Zoom. Is there any question? If you want to ask directly, it's also okay. But since there's no question yet, maybe we could discuss about the case. Probably, Evan, do you have any comments about the case previously presented by Dr. Rianti? I don't know whether Dr. Rio can join us already. Dr. Rio? He's still in the surgery room. So I hope he can.
Working hard.
Yes, working very hard. Do you have any comments about the case, Dr. Evan? Or question, probably.
Okay, Dr. Rina, I'm in here. So, yes, thank you.
Dr. Rio, you can join
Yes,
us?
Dr. Rina. Yes, yes, I just in between the surgery.
Oh,
So,
okay.
yes, thank you. But
Do,
this is
yeah, please,
yes,
Dr. Rio,
yes.
do you have question?
Yeah, I think I have a question for Dr. Evan Wong. Yeah. I think it's a very nice presentation. I just see how you make the data and it's very good surgery also there. And how about the DSO? You done with very nice technique, only 4 mm to remove the central area. But I have said some case that I also came to another meeting like a SCS, like I think last year. So I saw they said that DSO is uh, a little bit cannot be used because the prognosis is bad. But here you show us that still good for you for this is still a place for this DSO uh, to do in hook surgery. So any uh, tips and tricks how to do this DSO? Because in here very difficult to get the tissue. So we get the tissue from Nepal also and from US. And mostly in from Nepal we have to wait until 1 year for the patient to get
Oh,
the tissue.
yep.
Yes, and when for US, the price is very costly.
Yep.
It's about 4 times compared to Nepal uh, price.
Yep.
Yes, thank you, that one.
Yeah. Yeah, I think that I mean you raised that point about really patient selection. I think is very important in DSO. So those who have dense central guttae and central edema, but the periphery seems to be clear, indicating that there are healthy peripheral cells. I think that's really the key. And so
Okay.
if you in my presentation I showed the peripheral endothelial shot, so I could see that there were some cells in the periphery. And to be honest, I mean, in this case, I wasn't sure whether it would work, and I had consented the patient and counseled the patient that it might fail. But within 3 weeks, her cornea cleared basically.
Mm.
And just goes to show that those cells are have the potential to move to populate the central cornea.
Yes.
Yeah, but I guess you're right in the fact that that ultimately you may still need to do an endothelial keratoplasty. So I know that I have the backup here that I can waitlist them for a DMEK if I need to. Yeah, but I think that it's in the right patients it does. I wouldn't recommend it in pseudophakic bullous keratopathy, because in those cases you sort of expect that there are no viable endothelial cells. But for Fuchs particularly, I think it's something
Okay.
to consider.
Okay,
So
it's very
patient
nice.
selection is very important. Yes, Dr. Rio, sorry.
Yes, okay. I think that's all, Dr. Radis. So I think I have to come to your uh, uh, institute later, yeah, to see and how to learn from you also.
Yeah,
Because this is for DSEK, this is my I think I just like a newbie for DSEK surgeon. So this is the presentation done by Dr. Yanti. It is I think my 25th DSEK. Yeah, for the first second DSEK I failed the DSEK surgery and all the graphs really failed. And now they're starting to be good, but I think still need much learn from you also, Dr. Eva. Thank you.
Well, I would be very happy to welcome you to Perth and to come and
Oh,
watch and learn from each other. But I think that if that's your 25th DSEK, you're an excellent surgeon, and I think the surgery went well. I mean, I was very impressed by the fact that you can cut a DSEK in theater down to 21 microns.
mm,
yeah,
That's very, very impressive.
yes,
yes, okay,
We are quite spoiled here, so our eye bank
yes.
will cut the DSEK tissue for us. So it's a DSEK.
Mm,
So it comes pre-cut. And we typically, we don't, I would say the average thickness is probably 80 to 90 microns. So it falls into the
mm,
range of ultra thin rather than nanothin. And that's what we use. So sometimes I still do DSEK surgery as well. But not as thin as what you could cut in theater.
yeah,
mm. Thank you.
yeah. It's actually a very amazing what Dr. Rio did, right?
Yeah.
And of course, we also want to learn from your center about how to prepare a pre-cut cornea for the surgeons here in Indonesia. But I'm really interested in DSO also, and this I can see that Prof. Morgan also asked the question whether has anyone measured the average endothelial cell densities after surgery after some time period for this DSO. I mean, because it was hoped to be growth from the periphery, right? So anyone has calculated about that? Do research about that?
Yep. So if you see here, just highlighted, I've just brought up. Am I still sharing my screen?
Yes, you
Yep.
can see the screen.
Yep. So this is the central endothelial cell density there in the two groups of this meta-analysis. So the observation group is without ROCK inhibitor and then the ROCK inhibitor group. And so in the observation group only, it was 765 on average and over 1,000 in the ROCK inhibitor group. And this was I think this was a 1-year time point.
So yeah.
And in my patient at the 6-month time point, we got an endothelial cell count of 1,193.
In the central part.
In the central, that's right, yeah. Yeah, but it's also known that the peripheral cell count actually decreases when you do DSO. And that feeds into the theory that these are cells that are migrating from the periphery into the center. And I think some studies show that it went down by about 20% down in the periphery.
Yes. Yeah, I think everybody here in Indonesia will be very excited about the DSO because the technique is very easy. We can replicate that and practice
Yes.
about that. But the hard part is about the ROCK inhibitor. We don't have that drug yet in Indonesia. So you suggest that we better have that together with the DSO. But is there any alternative? I mean, like for us, like CMV endothelitis, we don't have the ganciclovir ointment, but then we can use something from the IV solution, and then we make eye drops. Is there any alternative for the ROCK inhibitor in the place?
So it's also, yeah, I'm not sure. I'm not aware of any alternative to use. We also, actually, it's a bit of a challenge to get it in Australia as well. We have to get it in the public hospitals. We have to get it under a special approval, special access scheme. In private, I'm very fortunate that Professor Morgan is in my building and I can ask his secretary because I think they order it in from Japan directly.
Oh, okay, I see. So maybe Dr. Evan, there's another question that is directed to DSO because it is really intriguing. Can you repeat again the best candidate of patients that you prefer to do DSO? And also for your case, you use the ROCK inhibitor. But for the selection of case, can you repeat that again? What kind of patient?
Sure. Yeah. So these are patients where the edema is more central and the periphery is still clear, which indicates that the peripheral endothelial cells are still healthy enough. Yeah. So these are cases of Fuchs endothelial dystrophy, not pseudophakic bullous keratopathy or other forms of bullous keratopathy. And cases where the patient is accepting of the fact that, number one, the visual recovery may take a while, and in fact, the vision may get worse than it started off with for temporarily, at least. And if it fails, then we'll be proceeding with a transplant surgery. And I think if those kind of basic things are met, then one can consider DSO.
Okay. That is very interesting. So, Dr. Rangga, I hope you get it clearly. What are the best candidates for this the DSO? But you have to remember that Dr. Evan suggested to give ROCK inhibitor also, that which we don't have it yet. So I will go to the question from Dr. Michelle. I think this is a very good question. Why do you prefer using SF6 gas over air bubbles? How does it impact on IOP post-op? And maybe you can also refer to the first case presentation, Dr. Evan, whether Dr. Rio should use the SF6 instead of the air bubble.
Yeah, so that's a good question. SF6 has been shown to have a slightly lower rebubbling rate than air for DMEK surgery, But for DSEK surgery, that's not the case. So for DSEK surgery, I still use air. I use filtered air for that. It's only for DMEK that I use SF6. Having said that, I know from a personal correspondence that in NEOS in Netherlands, where DMEK was invented, they only use air for that. So I think that people are trying different things. These techniques are still, in a sense, relatively new. But the way I was trained, we use SF6. There is potential for post-op IOP rise, which is why I do a peripheral iridotomy. And my post-op technique with DMEK is that we'll do a full gas fill and we leave that full. And then I check the patients at the bedside while they've been flat on their back for 2 hours. I check them at the bedside to make sure that the gas fill is still full. And then after that, I sit them up straight away. So then the bubble will usually clear, or quite quickly after that, it will clear the PI and they won't go into pupil block. But there is a little bit of it's a bit of a trade-off. Obviously, quite risky in patients with end-stage glaucoma and things. You always worry about snuff out with an IOP spike. But by and large, for the patients that I'm doing DMEK in, these we're sort of putting up with a slightly higher pressure, potentially for a few hours after the surgery, to make sure that the graft does adhere. And usually by the next morning, the bubble is down to about 60%, 60 to 80%. And I don't usually enforce posturing beyond the second day.
Okay, thank you so much, Dr. Evan. And maybe we can, and I hope Dr. Michelle have that clearly. And I think it's a clear answer. And maybe the next one, we should go to Prof. Morgan again. And I'm also curious about this. Prof. Morgan asked about if subsequent DSEK will be more difficult after DMEK, and whether there's a greater scarring type change in the central endothelial region of the cornea, which could possibly make subsequent DSEK more difficult. Because I was also intrigued by the data you have that the PKP have longer survival while DMEK is shorter. Is it better to have longer survival or repeating the DMEK all over again? Is it a better prognosis between the two in a long-term period?
I might have to get you just to clarify the question again. So the first question was, is there any challenges with doing DSEK after DMEK surgery? Is that correct?
Yes. Probably the question is, after DMEK, if it fails, is it more difficult to do DMEK or for other technique like DSEK? Or is there any risk about the central scarring? If the DMEK failed more early, right? So you have to do another surgery.
Yeah.
So is there any risk about the central scarring?
Where does the central scarring come from?
It's the question from Prof. Morgan, whether there's a greater scarring type change in the central endothelial region if the DMEK fails, and then it will make the next surgery more difficult. I think if I get your question right, Prof. Morgan, is it that kind of question?
Sorry, it might be a bit confusing. I meant really after Descemet stripping, where you've stripped out the central 4 millimeters and got endothelial cells growing back in, whether their basement membrane is different and forms a sort of more difficult Descemets to strip off if you're doing DSEK. Sorry, Rena, my question was a bit probably not very clear. Sorry about that.
Yeah, that's a very interesting question. So I've never personally done DMEK or DSEK after DSO yet. But I've read that what happens is the endothelial cells, they'll secrete sort of they'll secrete their own Descemet's membrane. It's not exactly like the original one, but from what I understand, it actually behaves quite similar. And so I think that there's not a huge issue in peeling that off or stripping that off if you're eventually going on to do a DSEK or a DMEK after that.
Right. Thanks. Thanks very much.
Yep.
So if we have a shorter survival for DMEK, would you prefer do multiple DMEKs than you do PK if you see in the long term? I'm just wondering because PK survive more, but DMEK have better result but survive less. Would you rather still do the DMEK repeatedly?
Yeah, so I mean, you can see from the trends in Australia that basically, even though there is this shorter survivability with endothelial keratoplasties, particularly with DMEK, there's still a huge move towards doing DMEK surgery. And I think that part of the reason is really, are the lower complication rates, is the quicker visual recovery. The patients are just a lot happier after DMEK or DSEK surgery because you're not dealing with, 7 diopters of astigmatism. You don't have to deal with broken sutures, suture removal. Potential, suture infiltrates and things like that. All those complications are gone. I think also, so I think that's the trend, and there's a reason for the trend is that doing multiple DMEKs is still in many ways more acceptable than doing doing a PK operation. Yeah, I think there's still place for PK, particularly if the DMEK has been there a long time and there's stromal scarring and things. People will still opt for a PK, but when it comes to just pure endothelial dysfunction, the EKs are definitely much more popular.
Okay. Is there any question from the audience? Probably wants to ask directly before we end our session. Maybe the last one, Dr. Evan, the
Sure.
CECI, the one that you establish in your lab, is it replicating the one that Prof. Kinoshita has, or you do something else different?
Yeah, it's slightly different from what he's doing.
Okay.
Yeah.
Okay, then maybe because it's already 8:07, I will end this session. But I really enjoy your talk, and Dr. Riri, you have presented very well about the case from Dr. Rio. And I hope everybody will get more knowledge tonight, and also encouraged to try to do DSO, and we will try to find how to have the ROCK inhibitor in Indonesia in the future. Thank you so much, everyone. So I close tonight. Thank you, Dr. Evan, Prof. Bill.
Thank you, everyone.
Thank you, Dr.
Thanks for
Evan,
having
Prof.
me.
Bill.
For
Thank
coming.
you,
And
Dr.
thank you,
Ladis.
everyone. Wassalamualaikum
Everyone.
warahmatullahi.
Thanks for attending, everybody. It's a great session.
Okay.
Thanks very much. Thanks.
Recording the picture, this.
Oh yeah.
Take-
Oh yeah. We have to
Take the
take
picture?
picture.
Okay.
I'm really sorry. Let's
Okay.
take the picture. Please open the videos for everyone.
Shall I
So
stop
And
the screen
they
sharing?
can.
I'll
Yes.
stop sharing.
Yeah.
Yeah.
Okay.
Okay. Who's gonna take the picture?
Okay.
This I will help taking the picture. Okay, so good evening, everyone. I would like to invite all of you to open up your camera so that we could conduct our photo session shortly.
I'm sorry, I'm still in the car. Mickey, I'm sorry.
It's okay, Dr. Firna. Okay, we'll wait a bit more, maybe 10 more seconds. Everyone, you could open up your camera, please. Okay, we'll start taking the picture now. Everyone give us your best smile. 1, 2, 3. Okay, second page. 1, 2, 3. Third page. 1, 2, 3. Fourth page. 1, 2, 3. And last one. 1, 2, 3. Okay, Dr. Ladis, back to you. Thank you very much.
Thank you so much, everyone. Good night.
Thank you. Good
Thank
night.
you.
Thank you, Dr. Ladis.
Yes.
Thanks.
Everyone.
Thanks.
Sorry, Prof. Morgan.
Hi.